Hello and welcome to the RPTH Research Recaps, where we dive a little deeper into the science being published at RPTH. My name is Eric Klok. I'm an internist in Leiden, the Netherlands, and I'm very pleased to introduce Dr. Stefan Noop. Dr. Noop is an MD, currently doing his PhD at the Medical University of Vienna, and is part of the Thrombosis and Hemostasis Research Group, the well-known group led by Prof. Ingrid Peibinger and Prof. Chian Ai. Dr. Noop's main research focused on venous thromboembolism with a recent shift to COVID-19 associated coagulopathy. He recently published his paper in RPTH titled Risk of Venous Thromboembolism in Patients with COVID-19, a Systematic Review and Meta-Analysis, which was the #1 ranked by its Almetric score in 2020 in RPTH. Dr. Noop, congratulations with this achievement, and we're looking forward to hearing your presentation.
Thank you, Dr. Klok. It's my great pleasure to present our recent publication on the risk of venous thromboembolism in patients with COVID-19 at this first RPTH research recap. So approximately 250,000 scientists dedicated this year to COVID-19, to better characterizing COVID-19, and especially for us in the field of thrombosis and hemostasis, COVID-19, a pulmonary disease, primarily a pulmonary disease, is of special interest as venous thromboembolism, the disease entity covering pulmonary embolism and deep vein thrombosis, ranks amongst the most frequent complications. Already early in the epidemic, studies such as the one performed by Dr. Klok reported very high rates of venous thromboembolism, especially in critically ill patients. But studies were highly heterogeneous, and VTE rates ranged from as low as 0% up to 85%. So what is the true rate of venous thromboembolism in COVID-19? And we aimed at providing an overall estimate of VTE rates in hospitalized COVID-19 patients. And we aimed at providing estimates of VTE rates stratified by healthcare setting. So divided into subgroups, we were looking at VTE rates of patients treated at an intensive care unit or patients treated in a general ward. And further, we wanted to look at rates in patients if DVT screening was performed or not. So therefore, we conducted a systematic literature research, including the WHO COVID-19 database, which provided us with an enormous amount of data, and studies which reported on patients with COVID-19 and on the rate of venous thromboembolism were eligible for inclusion. After a full text assessment, 86 studies remained for the qualitative synthesis. Next, we performed risk of bias assessment, and 20 studies due to high risk of bias were excluded. And the remaining 66 studies were included in the meta-analysis. So we used a random effects model to calculate the overall estimate and to analyze the subgroups stratified by setting. And in the following, I'd like to present our results. On the left, study characteristics of all 86 studies are shown. Most studies were conducted in Europe and North America. The majority of them included patients into cohort studies, and in 19 of those 86 studies, VTE screening was performed. On the right, characteristics of patients included in the meta-analysis are shown. So the mean age of all patients and also of those treated in an intensive care unit was 63 years. And what we already know from previous studies is that men were more likely to be hospitalized for COVID-19, and this gender gap even increases in critically ill patients. In this figure, forest plots of all 66 studies, including over 28,000 patients, is presented and separated into those where DVT screening was performed or not. And the overall estimate of all, the overall estimate of VTE risk of all studies was 14.1%. But probably the most interesting results were derived from the subgroup analysis. And the first subgroup we looked at were the subgroup of patients treated at an intensive care unit due to the severity of the disease. And those are facing a risk of VTE of approximately 23%. And the risk of pulmonary embolism in this subgroup was 13.7%. In the subgroup of non-ICU hospitalized patients, so patients treated in a general ward, the risk of VTE was approximately 8%, and the risk of pulmonary embolism was 3.5%. Further, we conducted additional exploratory analysis which results have to be viewed with caution, as this was not the primary intention of our systematic review. But there, men were at 1.45-fold increased risk for developing VTE. And those who had a VTE during hospitalization had substantially and significantly higher D-dimer levels at admission. Further, we observed a decrease of VTE rates over time. We analyzed this by looking at the last inclusion date of last patient inclusion date of each study. And we noted geographical differences in VTE rates, which we attributed to the different designs and study settings. So looking at our results, probably the most relevant question is the risk of VTE in hospitalized COVID-19 patients elevated? And on the left here, again, our results from the meta-analysis are presented and compared to data from the literature in hospitalized medical patients and a probably more comparable disease, namely influenza. And we can, I think, conclude that the risk of COVID-19, of the risk of VTE is elevated in COVID-19. So, of course, our findings have to be viewed in the context of several limitations. The first one being that the observation time between the studies was varying. So some studies reported on the VTE rate throughout the whole hospitalization, while some reported incidences on a certain period of time. Secondly, thromboprophylaxis could not be taken into account. We probably would have needed patient-level data on this. And further, we had insufficient data on bleeding complications, so we could not derive any meaningful conclusions on the rate and the risk of bleeding in COVID-19. And lastly, our data is based on studies from North America, Europe, and Asia. So the question is if we could extrapolate our findings also to other countries and continents. In conclusion, risk of VTE in patients with COVID-19 is substantial, and approximately 23% of patients treated at the ICU develop VTE. The risk of patients on general wards, so non-ICU hospitalized patients, was 8% in our meta-analysis. And whether some patients would benefit from intensification of thromboprophylaxis still remains unclear, especially as the rate of major bleeding complications in COVID-19 is definitely not negligible. But I'm hopeful that randomized controlled trials that will be released very soon will have first results and answers to those questions. Thank you very much for the attention.
Thank you, Dr. Knoop. Fantastic presentation. Well done. I have a couple of questions to you. And to start off, so you applied rigorous state-of-the-art methodology for this meta-analysis, but I do wonder, considering the significant heterogeneity between the study results, with I-squares of 70% of higher in all meta-analysis. Those were caused, of course, by differences in study size, applied diagnostic methods, diagnostic threshold beyond screening or no screening, clinical settings, prophylaxis taken, countries, ethnologies, and so on. whether you could have decided to show the results of the individual studies without performing the actual pooling. So what do you think should be the interpretation of the pooled estimates identified? Are these the truth as you intended to seek when you started off this endeavor?
Yeah, you're very right. I think this is the crucial point of our analysis. If pooling of the data was the correct choice, and we very much discussed this. And I'd like to be critical here now, looking back. Maybe the overall estimate of all 66 studies would be something that I would not include in redoing this again. But what I really believe is that the subgroup analysis, so the rates on venous thromboembolism in ICU patients and those treated in general wards, very much represent the true underlying risk of COVID-19, true underlying risk of VTE in COVID-19, at least for the first wave of the pandemic.
Yeah, I fully agree that there's much value to your study. I'm very glad that you decided to send your paper to RPTH. Another question is, how can we use the findings of your study in clinical practice or current or planned studies on preventing COVID-19 associated thrombotic complications?
Well, there was enormous amount of data on VTE in COVID-19 out there, and I hope with our study we could summarize and clarify those findings and to provide an estimate for the physicians treating this disease out there. Yeah, and regarding studies, I imagine it would be a good basis so the estimates would be a good basis to do power analysis, for example, for a randomized controlled trial in which thromboprophylaxis strategies would be assessed.
I fully agree. And my final question would be, you looked especially in the initial months of the pandemic, because I think you're looking to studies until halfway summer 2020. Now, the world has changed. We are facing in the second or even the third wave of patients. We treat them completely different. We have new viral mutations. Do you think this may have changed the incidence of COVID-19 associated thrombotic complications? And do you at least consider, let's say, repeating your analysis to take these changes over time into account?
Yeah, that's a very interesting question, because what we found in our data was that there was a subtle decrease of VTE rates over time. We performed a meta regression across all studies and looked at the last patient recruitment in each study, and maybe this decrease of VTE rates over time was due to better patient management, better thrombotic strategies, and I can imagine that this decrease would have continued now in the second and third wave. This is possible, yeah. And about the risk now with new mutations, probably the one arising in Great Britain, I can only speculate, but I don't know of any data that would provide a reason why the VTE rates would change with those. But I would be very interested in your opinion. Maybe you want to add something.
Well, I think that treating patients with high doses, really high doses of dexamethasone may actually improve prognosis with regard to survival, but may induce additional thrombotic events. And we've seen this also in some recent Dutch data, that we see an improvement of survival, but actually a comparable rate of VTE over time. But I think it's only a single observation, and I really hope that you would consider, let's say, repeating your analysis in a couple of months, looking for new subgroups, because those are the groups that are, those are the results that are mainly important for us practitioners. So thank you very much again for your great work, and I hope you publish again in RPTH.
Thank you very much as well.